3, 2.
Practice, and I'd like to welcome you today to the next of our wellness series, Living Well with Dementia. On behalf of this gathering, I'd like to take this opportunity to acknowledge the First Nation people of Australia and their elders, past, present and emerging. Today we have 4 speakers, and an outline of their training, research and roles is available in the video description below. Following their presentations, there's time for questions and answers, so please enter any questions you might have into the chat. Our first speaker is Professor Lars Ittner, who is the Director of the Dementia Research Centre and a Professor in the Department of Biomedical Sciences of the Faculty of Medicine, Health and Human Services at Macquarie University. Professor Ittner is going to discuss the current status of dementia research and its importance for developing new strategies to prevent and treat the disease.
So hello everybody. As first speaker, I'm going to give a short introduction on the topic and then show you some of our more recent successes in combating dementia. So dementia is an ever-increasing health problem for aging populations. Now every 3 seconds an individual is diagnosed with dementia, and that's most commonly Alzheimer's disease. But the causes are not known. There are risk factors for Alzheimer's disease, which include age as the one that we can't change. There are genetic risk factors like being an ApoE4 allele carrier. There's some other genes which are less important. And there are the modifiable risk factors, which my following speaker's gonna talk more about. Treatments for Alzheimer's disease rely today on 2 types of drugs, which are unfortunately very ineffective, and other forms of dementia have no treatments available. So there is a need for new treatments and also for novel targets. This is mortality data over 1 decade and its development, and we know now that dementia is the leading cause of death in Australian women and the 3rd contender in Australian men. When you look at the development of mortality for all major health diseases, and you look at this graph, you could take a pessimistic view in saying the prevalence of dementia and Alzheimer's disease is ever increasing, and this will become more with an aging population. There are continuous failures in drug development for dementia, and I'm going to speak a little bit more about this in a moment. So we are facing an emerging health crisis here. But I'd like to take a more optimistic view on this. When looking at all the other major health diseases like cancer, heart disease and stroke, over the past decade there was a major advancement that is due to basic science and discovery of new ways to treat these diseases. And now we are making these advances also in dementia, in the diagnosis of dementia, as well in studying brain function. So where for other diseases we have been 10 years ago, we are now emerging for dementia and Alzheimer's disease. So I believe that we will see advances in Alzheimer's disease treatment through discovery research. Over 100 years ago, Alois Alzheimer reported his first patient who presented with memory deficits, disorientation and hallucinations, and eventually succumbed to the disease. When he analyzed her brain, he found 2 lesions, the plaques that you see on the upper right, and the so-called tangles, which are filled up neurons in the brain of the patient. 100 years on, we are now able to visualize the pathology in living people. As you see here at the bottom right of this image, we can visualize the plaque pathology using advanced scanning technologies. However, the definite diagnosis relies still on histopathology to differentiate the different types of dementia. We have made advances in biomarkers for the disease, but they rely on either invasive techniques like lumbar puncture or using radioactive tracers and very sophisticated technologies. But the past 2 years have seen the emerging of new blood tests, and I believe in the next 5 to 10 years your GP will be able to make an accurate diagnosis of dementia with a blood test. Why have drug trials for Alzheimer's disease failed in the past? One of the reasons is that they have focused almost exclusively on one pathological change, the amyloid pathology. And you see here in this graph, all the red dots are clinical trials that have focused on amyloid pathology, while all the gray dots are rather unspecific treatments of brain function. This landscape has fundamentally changed. And you see all the colors on the right side. These are all now different targets that are pursued to develop and test new treatments. And so I believe there is true hope for breakthroughs in the near future. We have founded the Dementia Research Centre in 2018 to bring together 7 research teams that work in a multidisciplinary approach on dementia. We are now over 40 researchers and have established both mouse colonies and cutting-edge technologies to achieve in global collaboration with academia and industry accelerated discovery and drug development. And we are very fortunate here at Macquarie University to have a hospital and clinic on site with which we can align our basic research. We have now created a vibrant environment to enable cutting-edge discovery research with a focus on translating findings into treatments for patients. What happens in the dementia brain, in particular in Alzheimer's disease? There are 2 molecular changes. One is the accumulation of a protein called amyloid beta, which is cleaved by enzymatic scissors from a larger protein, and then induces toxic pathways and eventually forms the plaques in the brain, while another protein, tau, that is essential for the integrity of neurons, the brain cells, is modified in a way that it becomes toxic and deposits and presents eventually as neurofibrillary tangle. It was our work 10 years ago that identified pathways where both of these pathologies, amyloid beta and tau, act together to cause toxicity in the brain. And it took us another 10 years to identify a natural enzyme activity in the brain called p38 gamma that is protective by dissociating this pathway and preventing toxicity in Alzheimer's disease. Unfortunately, as you can see here on the data on the right, this p38 gamma protein, which is abundantly present in normal brains, as indicated by the zeros, is progressively lost as you progress in Alzheimer's disease. Therefore, we have devised a novel gene therapy that not only prevented the formation of Alzheimer's disease in preclinical models, and here we use mice, but we could show when in a more clinical relevant setting where mice have developed already deficits, representing patients seeing the doctor with memory deficits, that these mice could relearn lost memory functions and perform in memory tasks that are displayed here on the right side as their non-diseased counterparts. If you want to learn more about the research we're doing in the Dementia Research Centre, please visit our homepage, which is the easiest way to find is by typing dementia in Macquarie University into Google. And here you can find more about the people, the research we are doing. You have opportunities to get involved or support our research. If you have questions, feel free to directly email to dementia@mq.edu.au. Thank you very much.
Thank you, Professor Ittner. Our second speaker today is Dr. Rowena Mobbs, and she's a neurologist and senior lecturer in our Department of Clinical Medicine. Rowena subspecialises in cognitive neurology and is a leading clinician in dementia and concussion services. Dr. Mobbs is going to address the key question, when is memory loss a concern?
Thank you very much, and hello everyone for this exciting seminar. I'm a cognitive neurologist, so I'm at the coalface seeing dementia patients day in, day out, diagnosing dementia and managing dementia. And one of the points about this seminar is that we can absolutely manage people with dementia. It's not a case of you need to manage it on your own or there's nothing we can do. That's the old view. So I'd like to emphasise that today, working with a wonderful team at Macquarie University Hospital and MQ Health. So what is neurology? Well, it's the non-surgical side. So it's treating people, managing their symptoms, managing with medication, diagnosing them, rather than surgery. And so it's really the study of people as well as the study of the central and peripheral nervous system. So I really start to look at someone for their care. The minute they walk in the room, I'm really trying to observe them, listen to the patient, because they've got a lot to say, and the patient is trying to tell you something. So this is what I teach my medical students, that it's so important just to listen. We observe as neurologists a person's expression, their movements, their engagement in general social cues. We observe their weight and general appearance and well-being, and their body language and eye contact, their interactive style, their speech. Now, these are all clues to whether they may have an issue of dementia or not, in answering the question of is my memory loss a trouble or not? So this is what we try to do as a team at Macquarie. So I've got an example here of a patient.
Do we have there?
We have a pencil,
undergoing testing.
a
And so I'm
wristwatch,
asking the patient to name
kangaroo,
different objects
penguin,
for me.
an
And very
anchor,
often someone, for example, might
dromedary or a
name the anchor as a
kangaroo,
hook or the rhinoceros as a pig. And these are signs that they may have an underlying dementia. But it's putting together that whole picture as a person, observing them, understanding them as a person, and taking into account factors like their birth and development, whether they have any toxins such as alcohol or other factors that could play a role. So many people have a bit of memory loss with age, and this is one of the key questions that I'm asked. Is it significant? Do I need to worry? Well, there is a thing called mild cognitive impairment, or MCI, and this is a relative slowness of thinking or forgetting conversations, the odd name forgetting, for example, which we all can do, and forgetting the content of what conversation you might have had, losing your wallet, your keys, your glasses. These are, again, really common things. Losing the car, for example, that's a common one that I hear. Or losing track of the exact date. And of course, when you're a retiree, you may not know necessarily is it the 27th or 28th of the month. But these people are functioning normally. And so one of the things we can do within our clinic and our service is to reassure, if it's appropriate, and follow people over time to see if they do develop dementia, if they may be one of around 10% of people with MCI who do go on to dementia. So generally with Alzheimer's disease, I'm hearing the history from the patient, but of course from their family, what we call the collateral history. Now this is really important because it tells me two things. One, the sort of length of time that they've been affected, and a common time is 12 to 18 months that I'm provided, that memory has been affected for. Sometimes it's 2 or 3 years. The patient might notice only 3 or 6 months of decline. Generally, this is called impaired insight, so the patient may not realise exactly the degree of their memory loss. And this can be a sign of dementia. Classically, Alzheimer's disease, the most common type of dementia. They may not remember their episodes of forgetfulness. They can start to lose the names of people close to them. For example, IT can be increasingly hard, although again, it's all context. They can have confusions outside the familiar. So say if they go overseas, in pre-COVID times, they might be a little confused on the flight or in that environment. And they can have greater difficulty learning new information. It's the memories, the longer-term memories that stay longer. The shorter-term memories or the immediate learning tends to go sooner in Alzheimer's. They may lose empathy, and they may have changes in behaviour and emotion, like feeling agitated, irritable. People can feel anxious commonly, in fact almost invariably in dementia, and anxiety or a low feeling can emerge, frustration that you can't do the things you used to do, feeling less motivated to go out there and do activities, but some people can feel happier. There can be a change in mood that way. And often my patients are living very well through their dementia, certainly in the earlier stages. And so I really encourage that activity and engagement in life. Here's an example of what an Alzheimer brain looks like. So you can see the kind of shrunken appearance, the loss of volume of the brain, and with that the loss of weight of the brain. And you can also appreciate in the MRI image that there's some changes of volume of that brain. It doesn't look quite as full, and certainly not in the memory centres, the hippocampi that we look at. Alzheimer's disease may actually build up in midlife, or at least some decades before the onset of symptoms, and so that's what the arrow indicates. And there may be the build-up of plaques and tangles, as Lars has talked about. So who gets this? Well, we don't have all those answers as to who will get dementia. I'm often asked, oh, my mum or my dad has dementia, what's my risk? Well, not necessarily different to baseline. The older we get, the more common it is. So in our 90s, it's very, very common to have a degree of Alzheimer's. There are other brain conditions that can lower that threshold and make it more likely, such as any brain condition you could think of. The vascular risk is important. So we often see Alzheimer's disease with vascular changes of the brain. So if you've been a smoker of high blood pressure, you should be watched closely and try to modify your risk. ApoE4 is one of the factors we can't modify as yet. Anxiety and depression can play a role, so managing that well. And of course our hearing and our vision is how we perceive the world. So treating those factors is important for preventing, possibly, and managing dementia. And then genetics no doubt play a role. So where to from here? So I think if you're worried about your memory, even at the earliest time, that is the time to seek help. So you can see one of the lovely GPs here at Macquarie or elsewhere who will no doubt listen well and try to sort through your issue. It may be appropriate to see a neurologist or a geriatrician to investigate and look into things more. And many people want to know about dementia these days. They want to talk about it. So there's that sense of knowledge is power, and these days choice. So planning for future, for supports, for residents and where you'd like to be, all these sorts of things come into play rather than ignoring the issue. There are interventions we can do, like start memory tablets or improve your mood, for example. We know that social activity and exercise are really important, again, for prevention and management in dementia, and just good general advice, of course. The Mediterranean diet has a little evidence to it for preventing vascular risk. There's no disease-altering medication yet, but I, like Lars, am very hopeful that in my lifetime we will see that. But at the current, we're left with symptom management. So I really encourage you to seek help if you're concerned about your memory. It's a common issue, and I hope people feel confident that they can come and receive that help. Thank you.
Thank you, Dr. Mobbs. Our third speaker is Dr. Adam Bentz-Velzen, who is a psychologist at MQ Health Neuropsychology with an interest in ageing-related neurocognitive disorders. Dr. Bentz-Velzen is going to discuss strategies to best maintain memory.
Thank you, Heather, and thank you for inviting me here today for this talk. So today I'll be talking about memory strategies for mild cognitive impairment and dementia, probably more focused on the milder end of memory loss. Okay, so I'm a clinical neuropsychologist, and what is that? So I just thought I'd briefly introduce what we do. We're a psychologist that specialises in clinical neuropsychology, which involves the brain, thinking, mood and behaviour related to brain disorders, and this can include early neurodegenerative conditions such as Alzheimer's disease, stroke, traumatic brain injury and neurological psychiatric conditions. Sometimes a lot of those co-occur together. We also perform capacity assessments to see if somebody can, for example, live independently. We do a lot more, but I'll just brush over that today. I guess a question that a lot of people may have is, what is sort of normal cognitive change as you get older, and what may be something to worry about, which Rowena has touched on certainly in her presentation just now. So normal ageing is generally related to a slower rate of thinking, slower performance, and to remember things it may take a little bit more time, a bit more work, and maybe a bit more strategic type of thinking. Memory lapses are actually quite common for people at all ages. In fact, if we remembered everything, we wouldn't be functioning too well. Do we really need to know exactly everything that happened yesterday or on that really bad day several years ago? No. But when it becomes too prevalent, then that's a problem. As we get older, we actually improve in several areas of function. So now general knowledge of vocabulary and potentially aspects of social cognition, so the way that we relate to people, which is good. So it's not all one direction. I work at the Memory and Ageing Study at University of New South Wales, and we have done studies on super agers who barely change as they get older. So got a couple of examples there where they may actually be outperforming people several decades younger. So it's not necessarily Alzheimer's disease and dementia increases as you get older, but a debilitating decline is not necessarily inevitable, and there can be ways around that. So I won't speak for too long on mild cognitive impairment, as Rowena gave a brief introduction, but basically this is where you are having a greater than normal change in your function, a greater than normal decline in memory or attention, language, and so on, but you're still completely independent in your day-to-day activities, so it hasn't sort of really affected you in a clear sense in the day-to-day. Having mild cognitive impairment isn't necessarily a pathway to dementia. Occurs in roughly about 50% of people, and in fact in our studies we found that change can occur very rapidly, or it can take several years to occur, or you can actually revert back to normal. And so it's some bit of a mystery. You go MCI normal, and so on, and revert a bit. So we need to understand a lot more about what it means to have mild cognitive impairments. And dementia, adding to that, is it's where the cognitive changes are more severe and able to interfere with your independence in your everyday activities. Ultimately, at the end of the day, what all health professionals want to do is help preserve your independence and keep you living the life that you want to live as long as possible. So today I'm going to briefly talk about everyday memory problems. It's a very general term, and this is that type of problems that can occur with everyone, forgetting, say, a recent conversation, event or name, important information such as appointments, family birthdays, or forgetting to do things, what we call prospective memory, as in towards the future, so such as, again, taking your medications. And it's really, again, about the frequency that you have these memory problems. And so today I'm just going to talk about, very, very briefly, really touching the surface here, some different types of strategies that everyone can really use, particularly maybe the early stages of MCI dementia. So paying attention, this is something, for example, when we're trying to learn a new name, I personally find that I may need to ask a person twice or three times, can you just repeat your name just to make sure it sticks? So in learning new names, this can be really helpful, just to be basically telling yourself, make sure I try to remember this, and then you're just going to up that concentration a bit more and be more likely to remember that information. And it is actually a very frequent reason for memory impairment. It's not really memory per se. In neuropsychology, we'll call that attention. It's just that initial stage. Some other interesting type of strategies you can use that have been just time tested, and there's so much evidence for them. They've been used for a very long time. So here we've combined association, elaboration, and mental imagery. So for this one, you're basically imagining that your recipe is, the ingredients for your recipe are located in different rooms in your house. Now, because you know your house well, you know the plan, set up where things relate to each other, this really helps the memory stick because you're adding some new information there and it's just getting propped up. So that's one good example of effective technique, especially if you're having trouble remembering. Repetition may sound obvious, but this is sort of the eat your vegetables or eat your fruit and vegetables of neuropsychology is repetition, and space retrieval. So repeating the information, reminding yourself what that information is, and specifically when you're initially learning, remind yourself frequently, and then you can taper off and remind yourself, say, every half hour, every day, and so on. I guarantee you will not be forgetting quite as much information. External memory strategies, again, are time-tested and probably sound really obvious, but there's just so much evidence that they're effective. So a notebook or a diary could be physical, and these days we can use an app so that your diary can kind of come with you wherever you are to track future events and make detailed records of past events. Written reminders, especially in a timely location, especially where that location is relevant for that reminder, such as something on the fridge about what to eat or for your medications. and your alarms, and they can be superior to internal strategies, especially when you are having more memory difficulty. Having something around you to kind of guide you can be helpful. And and when you combine external and internal methods, then that can be particularly powerful. So memory strategies can be limited, of course, when cognitive impairment is sufficiently severe. So when you're really getting into the stage of Alzheimer's where you're, or dementia where you're just not remembering beyond sort of half an hour reliably, you may need a lot more external help. And those strategies will become much more external in nature, more about things on the wall to remind you of appointments and so on. If you're not motivated, then you're not going to learn. You've got to be able to work a little bit. So it's a bit like doing homework in a way, to remember things. If you have no insight that you have a problem, if you think, no, everyone else is remembering things wrong, I was right about that, everyone's against me, then we call that anosognosia. You're not aware that you have a problem. And that can be common sometimes in early dementia. And if you use computerized methods without supervision, so going on to cognitive training is this really hot topic in research and being increasingly taken up by neuropsychologists in practice. So in a nutshell, it's a sort of structured, repetitive practice for specific cognitive processes, like trying to we're going to make your memory better or your attention better. And they're becoming increasingly computerized, which potentially has great benefits in that you can do them from anywhere. But what we found, the researchers suggested that having supervision and follow-up with a health professional is by far the better way to do it, because you just simply get drop off with the cognitive training. So we are adopting that a bit more. There's good evidence that it helps with cognitively healthy people, so people that are already doing well, help boost them up a little bit maybe. Increasing evidence for mild cognitive impairment, some very good meta-analyses coming out. There is unfortunately less evidence for dementia, like it is with a lot of things, that once you're getting to that stage, then things may be progressing a bit quicker. But as Rowena touched on as well, there are so many things you can do for someone with dementia to help manage and make their life, quality of life better, and to help remember things as much as possible. And there is some evidence that comparing cognitive training to training a very practical skill, or so something that you have a goal to do, that you have a goal to, I want to be able to remember to get to the doctor, make my way there, and so on. Just a random example, could actually, something that's pertinent to you could actually be just as effective as training these perhaps more abstract processes like memory, attention in general, or a stimulating pastime that you've taken up can be really effective as well. So I think the jury's still out, but we are excited about the possibilities of cognitive training for helping people with memory difficulties. I would be skeptical of brain training apps. There's a lot of them out there. Some have some degree of evidence, but I wouldn't get too excited about this. I think the first thing to do is to go through a health professional to discuss that. So Viviana's following me with some modifiable risk factors, so I won't go into this in too much detail, but there are many other things you can do concurrently with memory strategies. So manage your cardiovascular risk, your mood, sleep, hearing or visual problems. There's been increasing attention to those, especially here at Macquarie University, some good research. Social isolation and just lack of stimulation and poor diet. All of these contribute to poorer memory and or acceleration of memory decline. Medications can help to some extent. There's potential that we'll get more medications with time that'll be effective. I'm hopeful as well. And having an early diagnosis of MCI or dementia can really help as well, because that means you've got timers on your side and you can do many more things at that stage to try and help yourself as much as possible, whether it's getting your affairs in order or actually trying these more active strategies. So one I didn't have there is more exercise. But I'll leave it there. So I'm Adam from Macquarie Health Neuropsychology. There's 6 of us neuropsychologists there. And so please contact us if you have any questions or would like an assessment of some kind. Thank you.
Thanks very much, Adam. Our fourth and final speaker is Professor Viviana Wuthrich, who is the Research Professor and the Director of the Centre for Ageing, Cognition and Wellbeing. And Professor Wuthrich will discuss reducing the risk of cognitive decline through lifestyle factors.
Okay. So this first slide is actually just to tell you a little bit about the centre we have here, which focuses on normal and abnormal aspects of ageing, cognition and wellbeing. So that's focusing on risk factors for dementia, helping people who have dementia, but also just we're broadly interested in ageing as a process itself. So we're interested in how people transition to retirement, what grandparenting is like, mental health for older people, thinking about how we maintain social connections in older life. So if you're interested, you can have a look at the website to find out a little bit more about some of the projects we have going on in ageing generally. But today I've been asked to talk to you about whether or not we might be able to reduce the risk of developing dementia. So you've heard from my colleagues that at this point, although we're working very hard on this at Macquarie, we haven't yet got a treatment for dementia. So in fact, because this has been a ongoing problem, over many decades we've been trying to think about, are there other ways we might be able to reduce the onset or the risk of developing dementia? There's been a lot of research following epidemiological studies. So these are where we follow populations over long periods of time and look at all the factors that might increase someone's risk for developing dementia. And by doing this, we've actually discovered that there is a number of factors that seem to be more likely to be associated with the development of dementia than others. Now, while some of these things we can't at this point intervene with, and so Lars actually mentioned these, so these are things like being older, that is a risk factor for dementia, being female, and there are other sorts of biological and genetic factors. There are some things that we might be able to do to reduce the risk of developing dementia in the first place. And it seems that by reducing these risk factors, we might also be able to slow down any decline that might have already started. So I think this is really hopeful in terms of being able to reduce the rate of decline for people who might already have some of that mild cognitive impairment that you've been hearing about. So there's been a number of studies that have actually tried to look at what are the risk factors, which are the ones that seem to have the most risk associated with these. So there was a systematic review which was done in 2011, and that particular review was the first one that came out, and it suggested that there are about 7 lifestyle factors where we might be able to modify to actually reduce someone's risk for dementia. This was followed up with a review in 2014, 2017, and the latest review, which has been led by Jill Livingston in London in 2020. And this particular review has looked across the lifespan and discovered that these are the particular risks that we know are most likely, if we could change them, to stop someone's chance of developing dementia. So you can actually see here that in the younger age groups, it's actually having less education. But we also know that this really relates to mental stimulation. So we know mental stimulation is something that's very important for people to maintain right from their childhood all the way through their life, because this reduces risk for dementia. You can see here on this slide a number of other risks that have been identified. In 2020, for the first time, we saw hearing loss being identified as a major risk factor for dementia. We also see air pollution coming in for the first time. Now, these are not the only risks that we have for dementia, but these are the ones for which we have the most evidence for. And so if you have a look here, you'll see, if you want to think about modifying your risk for dementia, the big candidates here are things like keeping up your mental stimulation, making sure if you are having any difficulties with your hearing, you get that assessed and checked and remedies as fast as possible. You can see that that is the biggest risk factor we have at the moment for dementia. You can see smoking, depression, and you can see physical inactivity and social isolation also playing key roles. There are some other modifiable risk factors that have been present in the scientific literature. They just don't have quite as much evidence as those other risks that I have just shown you. But you might have heard about the importance of managing your cholesterol, managing your diet. So there's a lot of attention being placed on maintaining fish consumption and fruit and vegetable consumption, and often Mediterranean diet is recommended. Pesticide exposure, we know, probably increases risk for dementia. There are cardiovascular risks, anxiety and sleep. So can we actually reduce dementia by actually getting people to change their behaviour? Well, it seems quite likely that that might be the case. So the early trials that were done really focused on one individual risk, and we looked at being able to modify those risks and the impact on dementia prevalence. And the results weren't particularly promising. We were able to see that we could modify the risk, but it wasn't often having much impact on whether or not someone would experience cognitive decline in the end. And it seems the reason for this is because these risks interact. All right, it kind of makes sense. If you have depression, you're more likely to also have low physical activity. You're also more likely to have low mental stimulation. You're probably more socially isolated, and your diet might not be great. So those things start to work together to increase your risk for dementia. So attention's really started to turn to interventions where we are trying to target as many of these risks as we can, not just one. And so, in fact, there's some research that's been done by Karen Anstey that's found that actually your risk for dementia increases with every risk factor that you actually have. So if you might have one risk, maybe you have a 20% risk in likelihood of developing dementia, and that increases the more risk you have. So there's been a number of large clinical trials that have been conducted now where they have taken thousands of people and gone and tried to reduce a number of the risk factors for dementia, and then really tried to look at whether or not that changes their cognitive ability over time, reduces their chance of developing dementia. So I've listed here a couple of the large trials. The first three are finished, but then we have some current trials that are happening. One here at Macquarie, which is just starting up, the ARU trial by the team here at Macquarie. We also have others at University of New South Wales, and we'll also be starting some new trials here at Macquarie as well, which I'll tell you about in just a moment. Now, what these trials have actually found is that they are able to reduce the risks. There is some promising evidence that they're able to impact on reducing cognitive decline, but we really need more evidence. And really, what I think we're learning along the way is that we need to make sure that we target the individual risks for individual people, rather than just trying to treat everybody for the same risk factors. Now, my research has been quite focused on treating depression as a risk factor for dementia. And that is partly because I know that we can very successfully treat depression in older people using psychological interventions. But also I think depression plays quite an important role in maintaining those other risks for dementia. As I mentioned, if you're depressed, it means you're less likely to have a good diet, it's less likely that you're going to be physically active, you might also smoke and have less mental stimulation. And so I think by targeting depression, we can actually increase the risk reduction of those other risks as well. So in one particular trial that we did here, it was a small trial, the Happy Healthy Aging program, we found that by treating depression and anxiety, we could also make successful reductions in risks related to alcohol, smoking, physical exercise, mental and social stimulation as well. But I think the key to risk reduction is helping people to first of all identify the risks that they have. It needs an interdisciplinary approach because we know that we might need psychologists, we might need audiologists, we'll need our GPs, we might need neurologists, we need a whole group of people to be able to help us to identify the relevant risks and to treat them in the best possible way with the best evidence-based interventions. I think screening is really important, so population screening to help people to understand their risk profiles. We need to be able to have risk interventions that are modifiable, that we can adapt to meet individual circumstances, or if we find a new risk is become apparent, we can screen people for that particular risk. And we certainly need to focus on building motivation to change. So as a clinical psychologist, I know that behaviour change is very, very difficult. We can do it, we can teach older people to change their behaviour, but it does require us to really encourage them and drive their motivation up to be able to make the particular changes needed to reduce risks and to sustain those new lifestyle habits. And I think psychological interventions really coupled with medical interventions is really the way forward here for being able to manage multiple risks at once. Now, the thing that's really exciting is that risk reduction is starting to move not just from being based perhaps in a GP primary care clinic, but to also being available in a whole range of other modalities. So, for example, we're starting to see risk reduction interventions that are being offered via the internet. So the Maintain Your Brain program, for example, is delivered via the internet. And we're starting to see other technology-based solutions that might use apps or other devices to help people to make changes to their risk. So here at Macquarie, for the next 5 years, I'll actually be focusing on a project where we'll be trying to do exactly this. Help people to be screened, to identify their individual risk factors, coordinated through their GPs to be able to modify as many of those risks as possible, building motivation for change, and then of course evaluating the outcomes. So one thing I just wanted to finish by saying is that while that risk reduction project is being set up, in the meantime we do have a particular project that's focused on reducing one of those risk factors, and that is risk of depression as a risk factor for dementia. So if you're interested, there's some information here. This is a particular clinical trial, NHMRC and Beyond Blue funded, that is designed to reduce risk for dementia by treating depression. It is remotely delivered, so during this COVID-19 period, it means you can actually receive high quality treatment from home without necessarily having to come into the clinic. So if you want any more information about that trial, you can see the details here. And so there are my contact details if you want to ask me any questions. So thank you very much.
We are eyes. We never stop searching. We are hands, warm like blankets and still with certainty. We are ears, loud or soft, we always hear. We are feet, carrying us on your journey. We are arms, always ready to fight. We are the fuel that supports body and mind. We are the brain. We'll never give up trying to understand. We are the heart. We beat with one purpose. In an Australian first, MQ Health integrates world-class clinical care, teaching and research with one goal in mind: to deliver the best for our patients and our community. We are MQ Health.
There have been lots of questions about the slides being available, and I did just want to mention that this presentation is being recorded and that at the conclusion of this live stream you'll be able to rewatch the full presentation at this site. So there's been a number of really interesting questions. Everyone's been listening to the talks. One question: why are ineffective medicines still being prescribed?
I think I better take that one, because we're often the culprits, aren't we? Look, I think doctors are very easy, hopefully recognising that they're not always perfect in their prescriptions, and that, as mentioned, it needs to be very tailored and individualised. And now, medication will always have potential side effects, and I emphasise the word potential. But we're mindful of that, or we should be. One of the hot issues at the moment has been the overprescribing of antipsychotic therapy and other classes such as benzodiazepines. You might have heard of Valium. And this can associate with falls and people ending up in nursing homes or being unnecessarily sedated and losing their function and increasing their impairment. So I, as a cognitive neurologist, are very acutely aware of that and would hope not to overprescribe or unnecessarily prescribe medication. We have a teaching in medicine to start low and go slow. So start low dose, go very slowly on the up titration of these medication doses. So hopefully we can adhere to that more and learn together as a medical profession.
Okay, thank you. What about the role of stress hormones and neurochemicals in accelerating cognitive decline?
I could talk about that. Hi. So very, very important. Chronic stress has been associated with poor health in general, a lot of different things, lower mood, of course, which in and of itself is a risk factor for depression, worse sleep, and I think probably less socialisation as well. And it's all sort of tightly tied together, as Viviana's talk at the end was illustrating. It's all tied together, and you can tease these apart. So I think with psychological therapy for stress would be really, really valuable, and part of it is also acknowledging what it is, acknowledging that you are stressed, and would benefit from some help. Sometimes medication can help, not necessarily the first line of treatment, but certainly I think medication plus psychological therapy has been known to be very effective in tandem together. Yeah.
Great, thanks. And on the same vein of psychological issues and the relationship, one question was, with elderly patients surviving their contemporaries, and that brings a lot of isolation and grief and maybe depression. Does it actually accelerate the decline?
It's an excellent question. I think it still remains a bit of an open question. I think it's certainly a risk factor if you are grieving, if you're feeling down, low, and I think when you lose someone that you love, the sense of identity and belonging and so on, and a support person as well. Absolutely. So I would say that there's that is a very big risk factor. Something that, as a clinician, I would be looking out for to try and alleviate where possible with services or support. But at the same time, I think the research has been showing that as well. So that is something that can become increasingly prevalent as people live older and older. That is more likely to happen. Mm-hmm. Sorry.
If I can add to that, so I guess we do know that social isolation is certainly problematic, and we do know that certainly depression and not having much social or mental stimulation is a problem. But that doesn't really mean that if you're the only person left in your family that you're necessarily increased risk for dementia. It really matters about how you cope with that and what you do with your time. And so there are a lot of people that live alone. In fact, a lot of elderly who live alone, and that doesn't mean they're all at increased risk for dementia. So I think the key is really thinking about making sure that time at home is busy, all right, so that people are engaging in lots of different tasks, so there's a bit of a routine or different activities, that you're learning new things, right, so talking to new people, getting out, and that you're just maintaining that those social connections. So I don't think it's doom and gloom just because your family members are no longer with you.
We'll come back to some more psychological questions in a moment, but can we speak on the role of exercise for a while?
Certainly. Well, I guess I'll kick off here just clinically. I see in my patients when they do engage in exercise, they're increasing well-being, and that goes for all things in neurology, really. Dementia is one of them, but headache and migraine you might think of otherwise, and many other conditions. So I think we all know it. It's the obvious common sense stuff, but to remain active is important. There's some latest work, I think, looking at tennis as one of the activities that might be leading the way as far as reducing risk, and there may be elements of coordination and social activity along with that cardiovascular and strength exercise. So I think that one of the keys, as we've highlighted, is to try to stay active but enjoy what you do, follow your passions, and that's certainly my general advice for people.
Yeah, and I think the physical activity helps because it reduces those cardiovascular risks, right? And also maintains weight, because we know that obesity is also a bit of a risk factor as well. And then I think coordination, keeping up gait speed, all those things are really helpful. So we do know that's one thing you should be doing right through life, is maintaining physical activity.
Okay.
And looking at the strength and the maintaining of muscle when you're older is really important. I think after the age of 70, you really shouldn't be losing too much muscle. You should be trying to maintain it. And so that's key for preventing falls and, of course, osteoporosis.
A question, there seems to be quite a family history that's relevant with Alzheimer's. Is there a gene? Is there a test? Will there be? Any information about that?
So there are a number of gene mutations that have been linked to Alzheimer's disease. So those that cause Alzheimer's disease, these are mutations in APP and other genes called the presenilins. Then there are a number of mutations that confer increased risk, like a TREM2 mutation. These tests or genetic tests exist. So if you have a family history of Alzheimer's disease or other forms of dementia, then genetic screening can be done to establish the risk of yourself and your loved ones. Yeah, I guess.
But if I can just add a hope, because I think people often think, oh, if I've got the gene, then it's a destiny. So the MAPPed trial that I referred to, so in their subgroup analysis, they actually found that the intervention was most helpful, actually, for those who carried the gene. So they were the ones where, by reducing their lifestyle risk factors, they were seeing the biggest benefit in terms of reduced cognitive decline. So I think it's definitely not because you've got the gene, it's guaranteed. It's more saying, hey, you really need to make sure you reduce those other risks as much as you can.
I can second that. When we refer to risk genes, that means increased risk. That doesn't mean you get the disease. For those that carry mutations, a bit different.
Okay. In relation to the brain training that you were talking a bit about, when should we start? Do you wait for the mild cognitive impairment, or do we all start at birth?
Yeah, it's a very good question. Yeah. I mean, to some extent, throughout our lives, we're doing brain training. We're doing lots of mentally stimulating things. Continuing your work into old age is very protective. But I would say it's never too late. It's never too early. So I think, staying as active as possible in all possible ways, socially, mentally, intellectually, pursuing your interests and your passions as energetically as possible is the best thing that we can do. And yet, never too late to start. Never too late to start a new thing too. So, if you'd like to try something new, Yep.
May I add to this? So there's a very interesting trial coming out of Tasmania, where they have selected elderly people after retirement to go back to university, and a control group which choose not to go to university. And within 5 years, they separated clearly in their cognitive decline. So it's indeed never too late to start. Yeah.
So on the same vein, then, what about research for building cognitive reserves? So I suppose before even the mild cognitive impairment. Anything additional to go back to uni?
Yeah, it's really interesting because a lot of this, it is super important to build cognitive reserve as much as possible. There's a lot of evidence now that this may be delaying the onset of dementia. You may stay cognitively well, just well in general, for longer and longer, and that it may have changed between generations. So current generation more likely to have better education, health as well. There's a lot of other factors that contribute to cognitive reserve. There was sort of this movement to, yes, if you learn a musical instrument, this will prevent dementia kind of thing. I think that oversimplifies things. In terms of motivationally, can you just start learning a musical instrument out of nowhere? I don't know. I think you can have more realistic new activities to keep you stimulated, certainly as you go. So, yes, did that answer the question?
And I think there's even some evidence towards gardening and well-being, growing vegetables, that kind of thing. So the simple stuff.
Okay. So some questions around diagnosis now, and really how is a diagnosis made? Yeah.
Well, the answer is we never fully diagnose it, and we don't have a test. It's only afterlife that you could ever be sure at an autopsy, and of course we don't often do that. So really it's putting together the pieces of the puzzle to say we have this weight of evidence to say that it's likely you've got Alzheimer's, or even a couple of types of dementia is not uncommon, or that you're in the all clear and we'll see you in a year's time. So things that we can do to help diagnose that are the clinical picture, so the history, we say, listening to that patient, examining them, MRI. We do EEGs, which is a brainwave test looking for epilepsy as an overlap of dementia. We can do things like lumbar puncture. We can do PET scanning, which is a metabolic picture of the brain. And of course, very good neuropsychology testing is a mainstay of diagnosis, and therefore individualised management and care of these patients.
Okay, thank you. Going back to one of our original questions was about the medications that are prescribed, and yes, you did talk about the use of certain medications exacerbating things like benzodiazepines and antipsychotics. But I think also in relation to some of the medications that are, marketed as Alzheimer's medications that are considered not that effective, but a lot of people really are very keen to be on them. So if you could just kind of outline a little bit, if they're not that effective, why is everyone wanting them, and where are we heading?
Yes, yeah. So I think it's about 300 medications that have been trialled in clinical trials, and we've only had 1 or 2 come through for efficacy on the symptom management, again, not changing the overall picture of the disease and the structure in the brain. One of those is an acetylcholinesterase inhibitor, so things like donepezil or Aricept can be used, and they can boost the memory and often boost the mood in about half of people, but they're not perfect medications. They only have so much effect. Sometimes we're surprised and we see very good improvements in people, enough to stay driving or stay in life in different ways. But many people don't, unfortunately, get a response. It doesn't change the overall picture, as I say. So we're all striving for those answers. Now, there's a lot out there, and we can look to the internet, and there are many articles and many research groups. I'm not sure how reputable they may be. There's a lot of people, I would say, who are looking towards dementia, and perhaps there's a financial driver there or other drivers that aren't scientifically based. And so here at Macquarie, we're very adherent to any science and evidence base for what we do, and I think that's important. We mustn't waste our resources and our time. If we're facing an early diagnosis of dementia, I think we should enjoy life and go with the evidence base, and we're all hoping that in the next decade or 20 or 30 years, 50 years, however long it takes, that we can actually treat and hopefully cure dementia or prevent it.
Okay, well, thank you very much. I'd like to thank our guests for wonderful presentations today, and thank you for tuning in.